Thanks for having me. I know it's just after the break and it's the afternoon, so right when you want to take your afternoon nap, but I'm going to do my best to prevent you from doing that, okay? So ENT disasters, know when to worry. So the first thing is, I know you know from having been through the course, is that we're doing the rapid lecture format, 18 minutes. I had 18 minutes to teach you about ENT disasters, and that seemed like kind of a tall order. So I did my research and figured out what can you really do in 18 minutes. And I found that in 18 minutes, you can find your focus and avoid distraction. You can do an entire load of laundry. You can learn the history of the world in 18 minutes. And of course, you can do the burnout, workout, and tone yourself and get in fantastic shape in just 18 minutes. And I think this one's kind of false advertising because it says 18 minutes, but then it says repeat. So I think that's the 38-minute workout, and they're hoping people don't do the math. But if you can accomplish all that, including learning the history of the world in 18 minutes, we can talk about bad airways, tracheostomies, and everything that can go wrong, okay? So we're going to start with a patient that I took care of, and as with most true horror stories from the emergency department, this happened about 10 minutes before the end of my overnight shift. 6:50 in the morning, true story, get a call from EMS. They're obviously flustered. You can hear it in their voice when they're worried about someone. 52-year-old male, acute respiratory distress. He's tachycardic, he's tachypnic, he's hypoxic. He corrects a little bit when you give him some oxygen, but not really as much as you would like. Oh yeah, and he has a history of a trach. I don't know anymore. We have an IV established at this time, and I'll be at your door in about 5 minutes. All right, so the first question really is when to worry. Well, now would be a good time to start worrying, when that guy's coming to your emergency department, and that's all that you know about him, okay? So tracheostomies, we do about 100,000 of them in the United States per year, and they have a very significant complication rate. It's about a 15% complication rate. Now, like with most things, most of those complications are going to be minor, but there are about 1,000 documented catastrophic tracheostomy-related events per year in the United States, and half of those result in patient death, and the other half result in things like anoxic brain injury. So truly, truly catastrophic events. And you may be thinking, okay, but that's going to happen when they're in the hospital and they're not going to show up on my door. But the truth is that most of them happen greater than 7 days post-op. It's not the immediate post-op period. So if someone went in for an elective tracheostomy, they're going to be home. When they come back, they're going to be seeing you in the emergency department. Okay, so what to worry about? Pretty much tracheostomy complications are divided into three areas: immediate, early post-op, and late post-operative complications. We're not obviously going to worry about the intraoperative or the intraoperative complications, but I couldn't resist putting this up because if you look at number 5. Number 5 is intraoperative fire. This is an article from 2000, and this made the top 5 of the intraoperative complications. So I couldn't, just for entertainment purposes, I could not put that up there. How often are people setting people on fire in the operating room? Anyway, okay, so we're not going to worry about those. But there's the early post-op and the late post-op, and the ones that we're really going to talk about, the ones that we really need to know are tube dislodgement, subcutaneous complications, and hemorrhages. Infection, unless they're really completely ignored, they're not going to put you in a catastrophic situation, but the others certainly will. Okay. All right, so hemorrhage, first off, bleeding from a trach. What happens? Well, clot disruption, right? That's why we bleed. Someone has a foreign body in their airway now. They cough because that foreign body is irritating that airway. They increase the pressures in their bronchial tree, in their trachea, and they blow off a clot, and they start to bleed. That can be kind of minor. You can have bleeding from the insertion site. That can be kind of minor. But then on the other end of the spectrum, there's this thing called the trachea-innominate artery fistula. The innominate artery runs along the anterior border of the trachea, and just by pressure, if you think about the curve of that tracheostomy that you put in, you can actually erode and cause a fistula. So it's rare. It's rare. It's less than 1% of the complications, but has a greater than 90% mortality. So if it happens, it's not subtle, and it's likely to kill your patient. The key thing here is what we worry about with so many other things in medicine and emergency medicine is you worry about the sentinel bleed, right? You can have a small bleed, small erosion that clots itself off. It can be up to 3 weeks earlier before the patient comes back. That fistula has really opened up, and now you're in a crisis situation. So bleeding from the trachea of any variety, of any quantity, is something that really needs to be taken seriously, even if it has stopped while the patient's in your waiting room or en route to the hospital. All right. So what do? Topical coagulant, that's fine, coagulant of your choice. If the patient has a coagulopathy, you're going to correct that, especially if someone's like anticoagulated because they're in the post-operative period. Obviously, you're going to address that.